Acrodynia, Wikipedia article audio. Acrodynia is a condition of pain and dusky pink discoloration in the hands and feet, most often seen in children chronically exposed to heavy metals, especially mercury. The word acrodynia is derived from the Greek, where alpha caparo omicron means end or extremity and omicron delta upsilon nu eta means pain. As such, it might be used to indicate that a patient has pain in the hands or feet. However, acrodynia is a disease rather than a symptom. The condition is known by a large number of other names, including pink disease, hydrogyria, mercurialism, erythredma, erythredma polyneuropathy, Bilderbeck's, Selters, Swift's, and Swift-Fear disease. Symptoms. Causes. Besides peripheral neuropathy and discoloration, swelling and desquamation may occur. Since mercury blocks the degradation pathway of catecholamines, epinephrine excess causes profuse sweating, tachycardia, salivation and elevated blood pressure. Mercury is suggested to inactivate S-adenosylmethionine, which is necessary for catecholamine catabolism by catecholomethyltransferase. Affected children may show red cheeks and nose, red lips, loss of hair, teeth, and nails, transient rashes, hypotonia and photophobia. Other symptoms may include kidney dysfunction or neuropsychiatric symptoms. Thus, the clinical presentation may resemble pheochromocytoma or Kawasaki disease. There is some evidence that the same mercury poisoning may predispose to Young's syndrome. Diagnosis. Mercury compounds like calomel were historically used for various medical purposes, as laxatives, diuretics, antiseptics, or antimicrobial drugs for syphilis, typhus and yellow fever. Teething powders were a widespread source of mercury poisoning until the recognition of mercury toxicity in the 1940s. However, mercury poisoning and acrodynia still exist today. Modern sources of mercury intoxication include broken thermometers. Therapy. Removal of the inciting agent is the goal of treatment. Correcting fluid and electrolyte losses and rectifying any nutritional imbalances are of utmost importance in the treatment of the disease. The chelating agent meso-2,3-dimercaptosuccinic acid has been shown to be the preferred treatment modality. It can almost completely prevent methylmercury uptake by erythrocytes and hepatocytes. In the past, dimercaprol and dipenicillamine were the most popular treatment modalities. Disodium edetate was also used. Neither disodium edetate nor British antylwysate has proven reliable. British antylwysate has now been shown to increase CNS levels and exacerbate toxicity. N-acetylpenicillamine has been successfully given to patients with mercury-induced neuropathies and chronic toxicity, although it is not approved for such uses. It has a less favorable adverse effect profile than meso-2,3-dimercaptosuccinic acid. Hemodialysis with and without the addition of L-cysteine as a chelating agent has been used in some patients experiencing acute renal failure from mercury toxicity. Peritoneal dialysis and plasma exchange also may be of benefit. Tolazoline has been shown to offer symptomatic relief from sympathetic overactivity. Antibiotics are necessary when massive hyperhidrosis, which may rapidly lead to miliaria rubra, is present. This can easily progress to bacterial secondary infection with a tendency for ulcerating pyoderma. The standard of care is discontinuation of the environmental exposure, and chelation therapy.